Okay, so assalamu alaikum everyone. I hope you're doing well. So my name is Hiba Raheel, and today I will be giving you a lecture on hypoxia and VQ mismatch. So going over this presentation and the PDF actually, and listening to the recording, I realized that it's somewhat a tough lecture. So I will try to make it as easy for you as possible. That's why I'm going to be annotating on my laptop because I want to dissect the PDFs and make sure that you understand everything. The presentation was actually made by my friend last year. Her name is Miral Al-Zaire. She's a third-year medical student now. And basically I'm just using her presentation and I'm going to be building on it, inshallah. Okay, so let's start first by talking about why oxygen is important. So can anyone tell me, why do we need oxygen? What is the importance of oxygen? Okay, so it's okay. The reason why we need oxygen is for an important process called oxidative phosphorylation. Okay, so oxidative phosphorylation is the process through which we get a very important molecule called ATP. Now, what is the responsibility for ATP? The ATP is a molecule that runs the important mechanisms in our body. Most of the cellular processes, cellular mechanisms, reactions, they rely on the production of ATP. So what do we need ATP for? We need it for cellular respiration. We need it for metabolism. We need it for excretion. And we need it for secretion. These are just like from the top, like just the surface reactions that we're talking about. There are so many things that we need the ATP for, and that is the importance of oxygen. Another very important protein or channel that is dependent highly on ATP is something called the sodium potassium pump. So sodium potassium pump has the responsibility of moving potassium and sodium, maintaining the sodium potassium balance. So what the pump does is that it pushes the sodium outside the cell under normal circumstances and brings in the potassium inside the cell. Now, when there is no ATP, this pump, it stops working. And as a result, what happens is that you have accumulation of sodium inside, and outside there is accumulation of potassium. Now, one very important rule is that wherever sodium goes, water is going to follow. Okay, so water literally follows sodium. Now, when this pump stops moving, sodium starts accumulating inside the cell. As a result, there is a rush of water. Water flows in the cell swells, and it bursts, okay, undergoing lysis, apoptosis, destruction, whatever. And this leads to hypoxia. So the lack of oxygen, this is what it does. This is the entire process that will start the chain reaction of hypoxemia. All right, now let's talk about the difference between hypoxia and hypoxemia. Hypoxia is basically when there is low levels of oxygen in the tissues. This is very important to know. And hypoxemia is low level of oxygen in the blood. So the problem is not with the tissue, the problem here is with the blood. In hypoxia, two things can happen. Either there is reduced delivery of oxygen, or the tissues are unable to utilize. Okay, so two things can happen. Either the tissues cannot utilize this delivered oxygen, or the oxygen is not being delivered in a proper manner. Hypoxemia is when there is just low oxygen in the blood. That's it. All right. Now, moving on to the different types of hypoxia. Okay, so here's where it's going to start, picking up pace, the lecture. So I want you to follow up with me. So first, we're going to talk about stagnant hypoxia. Now, the word stagnant, what does stagnant mean? Stagnant means to stop, to halt, to pause, right? So what happens in stagnant hypoxia is normally this is our blood vessel, and we have a flow of blood, right? Now, in stagnant hypoxia, what happens is that this is the blood vessel, and all of a sudden, there is this clot that forms. There's a blockage that forms, and it stops the flow of blood. So instead of the blood flowing normally, what happens is that it is met with resistance. Okay, so the delivery of the blood to the tissues is diminished, it's decreased. As a result, there is less oxygen being delivered to the tissue, and it results in hypoxia. Okay, anemic hypoxia. So it's in the name, anemia. So does anyone know what anemia is? You can type it in the chat if you don't want to unmute, it's fine. Low hemoglobin, exactly. So anemia is a disease in which there is low hemoglobin. And for those of you who don't know what hemoglobin is basically a protein that carries oxygen. It carries oxygen. So there is low protein, there's the blood has a low oxygen carrying capacity. So this leads to, obviously, when there is less protein available for the oxygen to be carried, there's going to be less oxygen that is going to be delivered to the tissue, eventually leading to hypoxia. Okay, and cytotoxic hypoxia, this is the last cause. In cytotoxic hypoxia, what happens is that the tissue itself cannot produce or cannot use oxygen to produce ATP. So there is some problem with the tissue itself. A very common example is cyanide poisoning. What happens in cyanide poisoning, I want you to remember this example because that's a very important clinical example. In cyanide poisoning, it diminishes the tissue's ability to utilize oxygen by destroying mitochondrial enzymes. Okay, so the three things we talked about: stagnant hypoxia, anemic hypoxia, histotoxic hypoxia. Okay, now let's move on to hypoxemia. Hypoxemia is basically when there is less oxygen in the blood. Okay, hypoxia was when we were talking about less oxygen in tissues. Okay, this is a very important differentiation that I want you to maintain. So what are the different types? There are 5 different types that are discussed. Number 1, low inspired oxygen, which means that oxygen is not, you are not breathing enough oxygen. There is a problem that the air around the air that you're breathing, it contains less oxygen. So what are those cases? For example, high altitudes. So when you go to the mountain areas, you will sometimes feel like you are running out of breath, or like you have to take in more breaths, or you're getting dizzy. That is because the oxygen content in high altitudes is very less, and in order for you to compensate for the lack of oxygen, we start hyperventilating, we start breathing faster. Okay, and this leads to eventually, if oxygen is not maintained, it can lead to hypoxemia. Next, diffusion limitation. So diffusion limitation, for you to understand what diffusion limitation is, we have to understand what pulmonary diffusion is. So what is pulmonary diffusion? Pulmonary diffusion is basically the diffusion of gases, the gas exchange that is occurring at the alveolar level in our lungs. So oxygen goes from the alveoli into the blood, and the blood takes up the oxygen and into the alveoli. So I'll draw that for you here. This is the alveoli, this is the blood. So the O2 goes inside and the carbon dioxide leaves. This is what is called the pulmonary diffusion. So when there is a diffusion limitation, what happens is that the alveoli they're getting the oxygen okay, but they're not getting it delivered to the blood vessels. So the oxygen is basically not going into the arteries. So there is a blockage somewhere here that is preventing the oxygen from being from going to, sorry, I'll remove that blockage because it's something else. So what is happening over here is that there is a problem occurring which prevents the oxygen from going into the blood vessels. Now moving on to hypoventilation. Hypoventilation. It's in the name. Hypo means less, ventilation. You're breathing less, okay? So what happens is that when there's no problem with the air that we're breathing. It contains oxygen, but we're taking in less oxygen because there is a blockade over here and we're breathing less. So there's less air, there's less oxygen, less gas exchange, and this can be caused by, for example, in COPD. So COPD, the lungs are obstructed. There is an obstruction happening in the lungs, mucus plugging, some mucus is stuck, and this causes the alveoli not to expand properly. Next, we're going to talk about the alveolar ventilation and perfusion mismatch. So in VQ mismatch, or the alveolar ventilation and perfusion mismatch, we'll discuss this later in the upcoming slides. And for this one, the right-left venous shunt, again, this one we'll discuss it further later. But basically, the shunt, what happens is that the deoxygenated blood, so the deoxygenated blood, it mixes with the oxygenated blood. So it mixes together, and the concentration of oxygen in the oxygenated blood, it goes down. Okay, now we're going to discuss these causes one by one. I think the first cause is pretty clear, that there is low inspired oxygen. That is one of the causes of hypoxemia, occurs in high altitudes. Is there any confusion regarding the first cause? If not, then we can move on. Okay, so I don't think that there is any confusion. We're going to move on to diffusion limitation. Okay, so basically diffusion limitation, here is where it starts picking up pace. So what happens in diffusion limitation is usually what is supposed to happen is this is the alveoli, and this is your blood vessel. So if there is 100, let's say, millimole of mercury of oxygen in the alveoli, the same number of oxygen should be present, the same amount of oxygen should be present in the blood vessel, in the capillary, right? So when the blood flows to the capillary, when the blood flows through the capillary to the alveoli, carbon dioxide goes into the alveolus, and the carbon dioxide, it goes in, and the oxygen, it comes out, right? So in diffusion limitation, the amount of O2 in the capillary does not reach the level of the alveolar PO2. So here, this is the alveolar PO2 at 100, and this curve over here, it shows you, the graph over here shows you the concentration of oxygen. As you can see, it's not up to the alveolar PO2. This is abnormal. Normally, what should have happened is that when the blood flows through the vein, and so PV means pressure of oxygen in vein, okay? So when it flows through the vein, it becomes a capillary. Over here, it's supposed to increase this way. So this is normal. This is what normally happens, okay? It increases and it becomes the same, the concentration of oxygen increases in the capillary, and it becomes equal to the pressure of oxygen in the alveoli. But because there is some abnormality, that is not happening. So normally the difference between alveolar oxygen and the capillary oxygen is 0. So ACDO2 is the difference between the oxygen in alveoli and capillary. It's equal to 0 normally. Okay, now when there's diffusion limitation, the ACDO2 becomes more than 2. So what do I mean by that? This is your alveoli, and this is your blood vessel. So if the alveolus has 100 millimoles of oxygen, in the blood, it's going to be around 80. Okay, so what is the AC DO2 in this case? 100 minus 80, which is equal to 20. And this is greater than 0. So this is the cause of diffusion limitation. All right. So when does this normally happen? The doctor didn't mention this, but I want to tell you just for the sake of like completion, this happens when there is lung damage, when there is infection, when there is pulmonary edema, or there is pulmonary fibrosis. Clear? Okay. Now we're going to move on to ventilation. So here we go. Okay, so ventilation. Normally, we're going to first talk about normal conditions, then I'm going to move on to abnormal conditions. So normally what happens is that this is your alveoli, okay, alveolus, and this is the capillary. This is the air that you're breathing and the air that you basically inhale. When you inhale air, it mostly has oxygen and very little carbon dioxide. It comes inside the alveolus, and at the same time, you have blood flowing. Blood coming from the venous side, so this is the venous side, and this is the arterial side, and this right here is your capillary. Okay, so when the blood comes from the venous side, as you can see, it has very little oxygen and it has very high amounts of carbon dioxide. Now this has to undergo gas exchange. The blood is flowing, oxygen is going to come in, carbon dioxide is going to go out, and as a result, when the blood leaves, you can see that the oxygen is very high. Now you're going to ask me here, why is there still carbon dioxide? The answer to that is you cannot remove all the carbon dioxide in the blood because carbon dioxide is needed to maintain the pH of the blood. This is a very, very important point here. If you remove all the carbon dioxide from the blood, you won't have the production of carbonic acid. No carbonic acid means no acid-base reaction occurs. The blood becomes too basic. So we want the blood to be at an optimum range between 7.35 to 7.45, and for that reason, we leave some of the carbon dioxide in the blood. Okay, so it's not something that you need to memorize, but you need to understand why the blood here, the arterial blood, has a little bit of carbon dioxide. All right, so this is what normally happens when you have normal ventilation. Also, as you can see that some of the oxygen here, it's 100, and over here it's 90. Why is there like a slight drop? The slight drop occurs because sometimes there's shunting, sometimes, it's not properly ventilated. This is normal. A small decrease in the level of oxygen between alveoli and capillaries is normal. Anything more than this, that is that is when we say, okay, there is definitely some abnormality. Now, what happens in hypoventilation? So in hypoventilation, something is obstructing the airway. The airway is blocked, and it's not allowing the air that we breathe in to come inside. So as a result, what you can see is that the oxygen concentration is 80. It's very little as compared to the air that we breathe in, right? It's 150 here and it drops down to 80. And look at the carbon dioxide level. The carbon dioxide is 60 over here as compared to over here, which was 40. So gas exchange is not happening. Ventilation is not occurring. So as per usual, the venule is bringing in the deoxygenated blood, which is 30 and 65. It passes through the capillary. Gas exchange is supposed to happen at this level, but some problem occurs and gas exchange does not occur because there's no ventilation, right? So when oxygen comes in, carbon dioxide has to leave. If carbon dioxide does not leave, it remains inside here. There is no gradient for diffusion to occur. As a result, what will happen? Carbon dioxide will remain inside and no gas exchange will occur at the level of capillary. So as you can see, when the capillary leaves, 60, it's still 60, right? So this is what happens in hypoventilation. Okay, so I'm going to stop here and ask you if you have any questions before proceeding. Okay. All clear? Perfect. Okay, I'll move on. All right, now we're going to discuss alveolar ventilation or perfusion mismatch. All right, so I'm going to spend a few minutes on this slide. Now, I want you to first, before we begin, I want you to picture the lung with me. So the lung is in the shape of a pyramid, all right? It has a broader base, as you can see, and it has a narrow apex, narrow top, broader base. It's shaped like a pyramid, okay? So inside the lung, we have capillaries, and we also have alveoli. The capillaries are what is responsible for the perfusion of the lung, because you know they're perfusing the blood to the lung, and the ventilation is what is the gas exchange that's happening. Okay, understood? So perfusion of the lung is higher at the bottom, at the base of the lung, right? Why is that? Because we have gravity. So at the base of the lung, we have increased gravity, right? Gravity pulls everything down. So the blood flow is higher down as compared to the top of the lungs. At the top, the alveoli are less perfused as compared to the alveoli at the bottom. All right. Now, for the ventilation, for this to understand, I want you to see how the lungs expand. So this is how the lungs expand. As you can see, the apex is not expanding as much as the base does. When we breathe in air, the base of the lungs are what expands more than the apex, right? And I want you to picture a spring. So a spring is when a spring is hanging, as you can see at the top, there's a lot more stretch. Can you see this? There's a lot more stretch at the top than the bottom, right? And it's the bottom part that moves more than the top part. That's exactly how our lungs are hanging. They're hanging like a spring by the top, by the apex. So what happens is that in the lung, the apex has the alveoli, which are mostly stretched. So they have less compliance, right? I want you to picture a balloon with me, okay? Picture a balloon. When you blow into the balloon, there is only so much air that the balloon can take. The more it stretches, the less compliant it gets, right? Because the more pressure the oxygen is going to exert on the walls of the balloon. And eventually, if you keep on blowing into the balloon, it's going to burst. So the same thing, I want you to apply the same concept for the lung apex. The alveoli are so expanded. They are literally so expanded. They're so big. They're so stretched in the apex that they cannot properly ventilate. So they have a decrease compliance as compared to the alveoli at the bottom. Over here, these alveoli, they will expand and they will recoil, okay? They will recoil and they will expand. They will go big and small, big and small, big and small. But the ones at the top, they're just expanded. They just have air trapped in them because they're so stretched. So this is called a decreased compliance. And at the bottom, at the base of the lung over here, the compliance is higher. Higher the compliance, more the higher the compliance, more the ventilation. Because when oxygen comes, the alveoli can expand. They have better compliance. At the top, they have poor compliance, low compliance, high stretch. They're very stretched, low compliance, low ventilation. Okay? Does that make sense so far? Before I move on, I want you guys to understand the concept behind the compliance. Okay, I'm seeing just one person. What about the rest, guys? If you don't understand this right now, tell me. I'll repeat it again. I don't mind repeating. Okay, I'm gonna continue. So, yeah, okay, perfect. So we understood this. I'm gonna recap quickly. Perfusion, more at the base of the lung, and also perfusion and ventilation are higher at the bottom of the lung, at the base of the lung as compared to the apex. Now let's talk about the VQ ratio. Now, what is the VQ ratio? The VQ ratio is important for gas exchange. It is the ratio of ventilation to perfusion. So ventilation is denoted by the letter V, and perfusion is denoted by the letter Q. So the VQ ratio is literally the ventilation divided by the perfusion. Okay, that is what VQ ratio means. We will take one part of the lung, we will check how the perfusion is, we will check how the ventilation is, we will put the numbers on top of each other, we will divide it, and that's when we get the VQ ratio. Now, VQ ratio is basically high. If a VQ ratio is high, what does that mean? So we have to talk a little bit about maths over here in order for you to understand this. So when we have a top number and we have a bottom number, right? Now, when we increase the number at the top, the answer is going to go up, correct? Let me explain how. So let's say that V over here is, let's say, 12, and Q over here remains 3. What's the answer? 4, right? Now, let's do the opposite. Let's decrease the V, and we will watch the answer going down as well. So let's say that the V in the second scenario is 6, and the Q is the same. The Q remains the same. What is the answer? 2, right? So what does that tell you? It tells you that as the ventilation increases, the VQ ratio increases, okay? Which means that as the oxygen is high, the carbon dioxide is low because the person has high ventilation. Remember, ventilation means bringing in oxygen. Perfusion means removing the carbon dioxide because carbon dioxide is in the blood. You're removing it. So as you're increasing the oxygen level, as O2 increases, your VQ also increases. Your VQ ratio increases. Understood? Because ventilation is increasing. You're breathing in more oxygen. You're bringing in more oxygen. You're ventilating the alveoli more. Gas exchange is happening. More gas exchange is happening. So VQ ratio is going to go high without taking out carbon dioxide. Now the opposite. Low VQ ratio means the opposite. Low PO2 and high PCO2. So, like I said, let's take the example where we are going to VQ ratio, okay? So let's say we will keep V the same and we will decrease Q. That means we will decrease perfusion. So ventilation, we'll keep it as 12, and ventilation, we'll keep it as 12. Perfusion, we'll make it, let's say, first, let's make it 3, okay? We'll make it 3. So what's the answer? 4, correct? Now let's increase it. Let's take that and we will make it 4. Automatically, it drops. So they're inversely proportional, right? So it's simple math. When you decrease the bottom number, the answer increases. When you increase the top number, the answer increases, okay? So you can use this logic when you're stuck in the exam and you don't understand, you can use this logic. And so one more time to recap, I'm going to say this again, this is an important slide, that the ventilation and the perfusion at the bottom is high, okay? And the VQ ratio is high because, why did I say the VQ ratio is high? It's because perfusion is high. Perfusion is higher, much, much, much higher than the ventilation at the base of the lung. Both of them are high as compared to the apex, yes, but when both of them increase, you will automatically think, okay, VQ ratio should be high as well. But that's not the truth. That's not the truth because both of them are increasing. They're canceling each other out. So VQ ratio remains low at the base, okay? At the apex, the VQ ratio increases. Why does the VQ ratio increases? Because the perfusion over here, so perfusion increases a lot more than the ventilation does. So at the apex, the VQ ratio, it decreases. Okay, so I'm going to explain that one more time. At the base of the lung, both the perfusion and the ventilation are high. So what ends up happening? The VQ ratio is canceled out. Both of them are high. They cancel each other out. VQ ratio is low. At the top of the lung, the perfusion is a lot more higher. It's more higher than the ventilation. So what happens? The VQ ratio, it drops. Okay, so the VQ ratio is is lower at the top. Is that clear? Exactly, directly proportional. Whoever said that. Yeah. Is this clear? Do you want me to explain the VQ ratio again? Or do you all understand? Can we move on? Okay. Um, okay, there's a question. Wait, isn't VQ higher at the apex from the arrows on the diagram? No. What arrows do you mean? Okay, how does it, wouldn't the ratio decrease as you go to the base of the lung? Exactly, exactly. So the ventilation, sorry, just so yes, you're correct. So the ratio decreases as you go to the base, okay? Why did I say that? Because both of the numbers are canceling each other out. Both the perfusion and the ventilation is higher at the bottom. They cancel each other out. And so what happens? The as compared to the apex, it's lower. Apex as compared to the base, VQ ratio is higher. Understood? That's what I meant. And in the diagram, the V is larger than the Q. Exactly. So proportionately, V is larger than the Q at the base of the lung. Oops. Okay. So how does that relate to tension? How does that relate to tension? So the tension at the top is higher. At the apex, it's higher. There's more stretch at the apex in the alveoli as compared to the base alveoli. That is how it relates to it. Okay, so again, this was the example that I used, the spring. All right, so for this slide, we are going to talk about what the ventilation and perfusion do. So if you did not understand the VQ ratio before, I'll try to make it more clear here, okay? So the ventilation takes oxygen into the lung, and perfusion takes oxygen outside the lung. Ventilation brings oxygen inside. You're ventilating, you're breathing. Ventilation means breathing, right? You're opening it, ventilating it. You're opening the alveoli, oxygen comes in. Perfusion, carbon dioxide is coming into the alveoli, and through perfusion, carbon dioxide is going to leave. Okay? Now, as we discussed earlier, the normal VQ under normal circumstances is 1. All right, how is that 1? Let's just create some hypothetical numbers. So alveolar ventilation, let's say from the top of our heads, is 5. All right, and the carbon dioxide level is also, let's say, 5. So V is 5 and Q is 5. So both of them will equal to 5 over 5, that is 1. So that's the number that we're going with. Normally, VQ is 1. In reality, it's 0.8, but just for the sake of simplicity, we'll make them 1, all right? But because let's say that so now let's say that there's a high VQ, there's a high VQ ratio, something happens. So first we were looking at here, this is it. This is your ventilation area. Q is your perfusion. So both of them, they will match and they will meet at, both of them VQ would be equal to 1. Now let's say that the VQ ratio is high. What does that mean? That means when VQ ratio is high, that means that it could be either due to increase in ventilation or a decrease in perfusion. So let's write it down. VQ. So we're saying that VQ is high. How would it be high? How is the ratio high? If the ventilation increases, because we said, remember, when you increase the top number, the answer goes up, or the Q is low. So the perfusion is low, okay? So let's apply that over here. As you can see, the Q, and this was the normal Q over here. And this was the normal ventilation at this point on this this area. This is the normal, right? So you can see that it is dropping, the Q is going from here and it's going up here. So there's a change, correct? There's a change. So higher the VQ, the higher the oxygen. And you can see that on this diagram. The oxygen went from 100 to 120, correct? The oxygen, it went from around 100 to 120. Ventilation increased. So the VQ ratio increased. Understood? Now let's talk about the opposite. Let's go to the opposite end, lower ratio. Now what happens over here? When there's a lower VQ ratio, it can be because of decrease in V or an increase in Q. So one more time, V over Q is equal to, let's say it's dropping. Okay, why is it dropping? So either the ventilation has dropped because they're directly proportional, ventilation and VQ ratio directly proportional. Oxygen and VQ ratio directly proportional. Or the Q, your perfusion is high, inversely proportional. Okay, now let's take a look at why. Why is that happening? So the over here before it was about 100. Now it's dropping to 80. The perfusion is, sorry, the ventilation, the oxygen level is dropping from 100 to 80. When that drops, your VQ level goes down. Understood? Is that clear? Is this slide clear, guys? Perfect. Perfect. Okay. All right. So right now we've just talked about O2. I've consistently talked about O2. O2 increases, VQ ratio increases. O2 decreases, VQ ratio decreases, right? Now, what about carbon dioxide? So recall when I said that PO2 increases, PCO2 decreases, right? They're inversely proportional. And because when we breathe in air, we take in all the oxygen from the air and we give out carbon dioxide. So that's why oxygen increases, carbon dioxide goes down. But this is only the case if the perfusion remains unchanged. That means the blood flow to the lung is remaining unchanged. You're not slowing it down, you're not increasing it, you are keeping it the same. So this part of your this part of the equation, the Q, you're keeping it the same. You are just increasing the ventilation, you're just increasing the oxygen, so the VQ ratio is going to go high, right? But now what happens is we're increasing the ventilation and their perfusion is staying the same. But if we increase in the oxygen and the carbon dioxide remains unchanged, this is what happens when you place the oxygen mask on a patient, right? You're putting in the oxygen mask on a patient, you are not increasing their blood pressure, the blood flow is the same, you're just giving them full 100% oxygen, their perfusion is going to stay the same, but the oxygen will increase and the carbon dioxide level will stay the same. You're breathing out the same carbon dioxide and you're inhaling more oxygen. Okay, this was just a little like clinical correlation. All right, now we're going to talk about what happens when there is an when there is a mismatch, when there's a VQ mismatch, okay? Now, I want you to take a look at this diagram. I have divided it into two, okay? We're going to divide this diagram into two here. Look at this side first, the A1 side, okay? The alveolar region 1 side. In alveolar region 1 side, we have high ventilation. The ventilation is high. Can you see how thick the arrows are? But the perfusion is low. Do you see how tiny, thin the arrows are here? So high ventilation, high ventilation, low perfusion will lead to a high VQ. This is what it says. VQ ratio is high. And when will this occur? In hyperventilation, when we're breathing fast, such as when we are in high altitude. In high altitude, there is less oxygen. We need to compensate the less oxygen by breathing in more. So that's why when you go up to the mountains, you get short of breath. You start breathing in more, right? So hyperventilation occurs when there's hyperventilation causes high VQ. Now, in region 2, you can see that we have low ventilation, and at the same time we have low ventilation, sorry, and at the same time we have high perfusion. Do you see how thick, like we've expanded the blood vessels here? What will happen as a result? low VQ, right? Because ventilation goes down, VQ goes down. This occurs in hypoventilation. Hypoventilation means decrease in ventilation, and VQ ratio also goes down. So I've mentioned this a couple of times, but I'll say it again. So to really drill in the concept, higher the VQ, higher the PO2, which means more ventilation. All right. So in alveolar region 1, there is higher PO2 than the alveolar region 2, if you look at the right side of the diagram. Okay. Now in reality, our body's oxygen level is not measured on just one alveolus, right? It is accumulative of all the alveoli in the body, in the lung, right? So they are all mixing up together. So somewhere, some alveoli will have a high, some place the alveoli will be like this. Some place the alveoli will be like this. Some place it would be high ventilation, low perfusion. Some places there would be low perfusion, high ventilation. So it's all basically a mix, okay? So same goes with arterial PO2. Some places the arterial PO2 will be more perfused, like it would be higher than the alveoli. Now, the alveolar and the capillary PO2 difference, as we mentioned before over here, the alveolar and the arterial PO2 difference, is basically the arterial PO2 has to reach the PO2 of the alveoli as much as you can. Do you remember that graph that I showed you? That curve has to go as high as it can, as much as it can. Well, in that slide, we saw that it doesn't reach that high, right? So we have an unequal distribution of ventilation and perfusion. This is known as VQ mismatch, or that would lead to hypoxia. In normal lungs, VQ mismatch is normal, okay? Not all of our alveoli are ventilated the same, not all of them are perfused the same. But however, if this normal mismatch stays in the normal range of about 3 to 10 millimole per mercury, then that's fine. But if it increases above than 10, then that is a problem. This indicates that there's a severe VQ mismatch, that there is hypoxia, and this can happen in numerous problems like pulmonary embolism, asthma, COPD, a lot of problems. One of the examples is this picture that I have showed you over here. So I got this picture from the video. So you can see there are two alveoli, but this alveoli, it has water in it, okay? This alveolus has water. This is called pulmonary edema, when there is water inside the lungs. So what happens is that this water is blocking the ventilation. So the oxygen cannot go from here to here. Oxygen is not able to go. That's why the perfusion is 99%, less than 99%, okay? So when there is a blockade in the alveoli, this blocks the ventilation, and this decreases the VQ ratio. Remember, V is at the top. You decrease ventilation, you decrease the numerator, the top number. VQ also decreases, right? They're directly proportional. They'll go down together. So VQ ratio decreases, becomes less than 1, and this is on this side, right? I'm talking about this side. Now, as for the right side, this side of the picture, over here, everything is normal, everything is fine. The alveolus is well ventilated, perfusion is occurring, and the VQ ratio would be about 1 over here. Okay, so due to the less ventilation on the left side, the arterial system blood is not well oxygenated. This will, so that means that the right amount of oxygen will not be delivered to the cells, leading to hypoxia, and eventually cell death. Okay, so right now we spoke about the VQ mismatch, the VQ everything. The VQ mismatch, was it clear, guys? Do you want me to repeat anything before moving on to the shunts? The edema is inside the alveolus, yeah. So there's water inside the alveolus itself. Perfect, great job. Okay, so now we're going to move on to our shunts. Okay, so there are two types of shunts, the right to left shunt and the alveolar dead space. By the way, you guys, we're very close to finishing. So, if you've hung out this far, you're going great, okay? Now we're moving on to the relatively easier part. So the VQ shunts, the normal shunting. Let's first talk about what an ideal alveolus is, just under normal circumstances. Ideally, what happens is you can see that the PA is the pressure of oxygen inside the artery. P capital A is the pressure of oxygen inside the alveolus. Oxygen is going to come in, blood is flowing from the venous side to the arterial side, and the ventilation is going to occur, perfusion is going to occur. Okay, this is going to result in a VQ ratio of 1. All right, 1. Now let's say that there's a shunt that occurs. Now first we're going to look at the left side of the diagram. So over here, in the left side of the diagram, you can see that we have blood flow, but we don't have ventilation, right? The blood flow is occurring, the perfusion is fine, but the ventilation is not fine. There's a blockade here. There's something blocking the alveolus. So the blood comes in from the venous side to the arterial side, and it does not get oxygenated. So this is considered to be the right to left shunt. And we don't have ventilation, or our V would be 0. So 0 divided by anything is going to give out 0, right? So let's put that theory into test. V over Q. So our ventilation is 0. Let's say our Q we said was 5. What would this give us? 0. So this is your VQ ratio, 0. Okay. Now let's look at this side. Now this side of the diagram, on the right side, we can see that we don't have perfusion. So over here, there is a blockade in the artery itself. The alveolus is being ventilated. There is no problem there, but the problem is actually in the arterial side. There is no blood flow. So what happens is that this could be because of an embolus, or it could be blocked in the blood system, and it creates a dead space. So I think you covered dead space in one of your previous lectures, but basically, just to quickly recap, a dead space is part of the lung that has the ventilation but does not participate in gas exchange due to the lack of blood supply. There is no blood flowing, there is no difference gradient in gas exchange, no diffusion of gases will occur. As a result, this space will become a dead space. There's air, the alveoli will expand, they will expand. Air comes in, it will expand. However, it's dead. There's no gas exchange occurring. So when we don't have perfusion or blood supply, our Q will become 0. So our denominator becomes 0. And remember, anything divided by 0, what is it? If you enter it into the calculator, it gives you an error because it's infinity, right? So we'll put that to test. So V over Q. V, let's say we're going to keep it as 5, but our Q is 0. And what would that give you? It will give you infinity. Put it into your calculator right now. Open your calculator and put that 5 or any number when you divide it by 0, it's going to be infinity, okay? So that's why the VQ ratio over here would be infinity. The VQ ratio over here would be infinity. All right? Okay, now the binding curves. Now this curve, it seems more complicated than it actually is. It took me a while to understand this as well, but basically the gist of it is that whenever we talk about the VQ mismatch, we said that I've mentioned it again and again that oxygen. As oxygen increases, VQ increases. As oxygen decreases, VQ decreases, right? But I don't mention carbon dioxide. Now, why is that? Now, as you can see over here, we have a graph. We are plotting concentration versus the partial pressure of carbon dioxide, and of oxygen. So this curve is for oxygen, this curve is for carbon dioxide. Now, just by looking at it, there are two things that you can tell me straight off the bat. Oxygen has a less steep curve, carbon dioxide has a steeper curve. The slope is steeper, oxygen is a little flat, right? You can see this. Now, over here, they're plotting two areas, arterial and mixed venous. This is arterial, this is mixed venous. you can clearly see that in the arterial side, the partial pressure of oxygen is 100. But as it goes to the mixed venous side, it drops down to about 40, correct? So it decreases. There is a difference of 60 millimeter per mercury partial pressure of oxygen. So I heard in your lecture he used the example of the legs. He said that as the blood flows from the lungs to the legs, the partial pressure decreases. It makes sense because the more the blood is flowing, the more oxygen is being consumed. So the partial pressure of oxygen drops. Here it's dropping about 60, and even the concentration has dropped about 50. Okay? Now, let's look at the carbon dioxide level. Now, carbon dioxide level in the arterial side is about, let's bring it down. And it's about 40, okay? And in the mixed venous side, it's increased. It's about like 45. Again, the increase is not that high, right? So the increase is not that high. It's only changing for about like 5. So compare 5 CO2 with 60 for oxygen. Do you see the massive difference, right? We had 5 over here and we have 60 over here. That's like a big difference. So the difference in oxygen is way more compared to the carbon dioxide. And this is why a change in carbon dioxide is very minimal and is very minimal to the VQ ratio. That's why a small change in oxygen will cause a VQ mismatch, but a change in carbon dioxide will not cause a VQ mismatch. And why is that? Why is the change small? Go back to the first slide. Go back to what I said at the beginning, because we want a little bit of carbon dioxide to remain in the blood at all times for cellular functions, like for example, for maintaining the pH. Okay. All right, guys, is it clear so far? Is there anything that you want me to repeat? Can I explain the shunt again? Okay, and can I re-explain the arterial alveolar difference? So do you want me to go back to the slide? Okay, so the arterial alveolar difference, right? So over here, we are talking about, this is the normal situation, okay? This is what happens normally. The artery, the alveoli, if it's supposed to have 100 oxygen, the artery is supposed to have 90, not a big difference. That's what normally should be happening. Now let's see, in right to left shunt, there's a blockade here in the alveoli. Okay, there's a blockade in the alveolus, and the blood is flowing. The blood is flowing normally. Perfusion is normal, but what happens is that oxygen is coming, but it's unable to go past this blockade. It's unable to go into the alveolus, and it's unable to go into the blood vessel. So what happens over here is that the V, so we're going to go back here. The V is 0 because, it's blocked, so it's absolutely 0. And the ventilation, the perfusion is fine. Perfusion, we're going to give it 5, the normal perfusion number. So 0 divided by 5 becomes 0, right? Simple math. That's why the VQ ratio is 0. Now let's look over here. Over here, I will actually take this part. I will bring it here so you guys can understand. Okay. All right. So over here, you can see that ventilation is occurring normally. Gas is coming inside. However, there is a block here. There is an embolus. There's something blocking the artery. Now, when there's something blocking the artery, what happens is that blood is not flowing. Blood is not moving past. It's not going to the alveolus. Gas exchange is not happening. So your perfusion becomes 0, but your ventilation is normal. It's 5, the number that we assigned, 5. But the Q literally becomes 0. So anything divided by 0, if you place 0 in the denominator, the thing would be infinity, right? The VQ ratio would be infinity. So this is the difference between, and this is the alveolar dead space. This is what is called the alveolar dead space. All right, now over here, the curve again. So I'll talk about the curve one more time. Okay, so here, if you see, I'm going to start from the beginning. Let's cross all of this out. Okay, so over here, we are looking at a graph that has concentration and partial pressure of oxygen, right? So concentration is the y-axis, partial pressure of oxygen is the x-axis. Now we're looking at two graphs. We're looking at carbon dioxide and we're looking at oxygen. Now, right off, like just by looking at these two graphs, you can tell that carbon dioxide graph is very, very steep, right? And this graph is very flat. Look at this, it's very flat. The oxygen graph, flat. Carbon dioxide graph is very steep. There's a nice slope. There's a very nice slope. So in oxygen graph, what are we looking at over here? I want you to focus on these 2 points. Okay, let me use another highlighter. So I want you to focus on mixed venous and arterial. I want you to focus on these 2 points and see. In the arterial side, the partial pressure of oxygen, let's go down, let's see, it's 100. Correct? In the venous side, let's go down, it's about 40. So what is happening? As the blood is flowing from the arterial side to the venous side, the partial pressure of oxygen is dropping. There is a difference, 100 minus 40, there is a difference of 60. So the partial pressure of oxygen is decreasing by 60 millimole per mercury. Arterial side, this is where, let's say, the lungs. In the lungs, the VQ, the partial pressure of oxygen is 100, correct? As it moves down the body, goes to our arms, the legs, the chest, the abdomen, moves down to the legs, it decreases. Oxygen is being consumed. It is decreased. It goes from 100 to 40. So this difference of 60, this is the difference of 60, okay? Now let's look at carbon dioxide. Again, for carbon dioxide, I want you to focus on the arterial and the mixed venous sides, 2 points in the graph. Now, the arterial side, as you can see, the carbon dioxide level is 40, okay? And as it goes to the venous side, it increases. Okay, let's say now it is about 45. I would say 45, okay? So it changes to about 5. So can you tell that the change between 5 and 60, can you imagine? 60 is so much. The partial pressure of oxygen changes so much more than the partial pressure of carbon dioxide. What does that tell you? That tells you that the difference in oxygen is way more as compared to carbon dioxide, because there's a very minimal change that is occurring. That's the reason why oxygen, partial pressure of oxygen, has a greater effect on the VQ ratio as compared to the carbon dioxide. It's because of the steepness of this curve. Understood? Is this clear now? Taline, I'm asking you, is it clear now? Because you didn't understand it. So if it's not, then I can further explain it, but like in a little bit, okay? So I'm gonna move on. If there's any question that you have, you can put it in the chat and like I will answer it towards the end of the lecture. We're almost done. Okay. So one last thing that we're going to talk about is the right to left shunt. We already kind of spoke about it, but I just want to mention it again. The right to left shunt occurs when the venous blood does not go to the alveoli to get oxygenated. There is a block, something happens, right? Now there's a shunt that's occurring. What is a shunt? A shunt is a pathway, it's a diversion, okay? So it automatically goes and mixes with the arterial blood. This causes the arterial blood to not be oxygenated, and it leads to hypoxemia. And this condition occurs in something called VSD, ventricular septal defect. When there's a hole in our heart, the oxygenated and the deoxygenated blood, they mix together and the partial pressure of oxygen decreases. Understood? Okay. Now, causes of hypoxemia. So what are the causes of hypoxemia that I want you to know? So some of the causes, these are the causes that are mentioned. Now, why is this important? Why must we know about this? The reason why you need to know is because if a patient is coming to you and they have low oxygen saturation, you need to identify why do they have low oxygen? What is the cause? You have to identify it because that will shape your treatment, correct? So low oxygen in the blood can be because of these 5 reasons. Now, I'm going to go step by step how you can tell. First of all, I want you to focus with me on PaCO2. Okay, PaCO2 and hypoventilation. In hypoventilation, PaCO2, what is happening in hypoventilation? You're breathing in less. So this is your alveoli, and this is your blood vessel. There is a blockade over here. There is hypoventilation. So oxygen is not coming in and carbon dioxide is not leaving. There's a lot of carbon dioxide in here, but it cannot leave. So as a result, what happens? That the carbon dioxide in the artery, it increases. And that's why it's high, because it's not leaving. It can't leave the alveoli over here. Now let's talk about low PiO2. Low PiO2 is inhaled oxygen. So again, let's take an example of this alveoli. That's a very bad alveoli. I'm going to take this alveolus over here. Okay, here we go. So this is the alveolus. Now, what is happening in low PiO2 is that we are inhaling less oxygen. Okay. Now, I told you when we inhale less oxygen, let's say at high altitudes, we need somehow, there's less oxygen in the air. Now, somehow our body needs to compensate for this less oxygen. Otherwise, what is it going to do? Is it going to die? Of course not, right? We have to do something. Our body has mechanisms for everything. So when there's less oxygen in the air, what will end up happening? We will start breathing faster, right? We will hyperventilate. Hyperventilate to bring in more oxygen. So the alveolus can open, the alveoli can open more. So it's exactly the opposite of hypoventilation. In high altitude, we are actually hyperventilating. Okay, so as a result, carbon dioxide will be low. Why? Because we're hyperventilating, gas exchange is occurring very fast. Oxygen is going in, carbon dioxide is going out, and this is occurring a lot. Carbon dioxide going out, oxygen coming in. So this is happening at a very fast rate. That's the reason why our arterial CO2 levels would be low. Okay, understood? Now, we are done with both of these, so we'll just cross them out. Okay, we're done with them. We're going to cross them out. Now, we're going to focus on the top three. Let's focus on the top three. Now, first, oops, sorry. So let's focus on these top three. So, let's say that now there's three more causes of VQ mismatch, right? Three more causes of hypoxemia: VQ mismatch, right to left shunt, and diffusion problems. So remember how I told you that the AADO2, which means that capital A, this one, is alveoli, artery, difference of carbon dioxide, or alveoli, artery, difference of oxygen. Okay, so that's what it means. So their AADO2 is what can remain changed or unchanged. So what happens is that the AADO2 of these three are high. Can you see? They're all high. Now, what we have to do, so now we're going to check if their AADCO2 it remains unchanged or not unchanged. How will we do that? We will give them oxygen. We will give them 100% oxygen. We'll give the patient 100% oxygen. If we give 100% oxygen and there is no change, we know the cause is right to left shunt. This is the cause. We gave 100% oxygen and it remained unchanged. No, it remained unchanged. The problem is right to left. The problem is right to left shunt. Why? Do you remember what I told you? Because no matter how much you're perfusing, you're giving in air, you're giving in air, you're giving in air, but the blood is not flowing. There's right to left shunt. The blood is not flowing. That's it. There will be no change in oxygen, right? It makes sense. So the blood, because the blood in the first place, it's not getting ventilated. It's not going to the alveolus. It's getting shunted. So that's why no matter how much oxygen you give them, their blood is being shunted. There's carbon dioxide in it. It's never going to be completely 100%. Understood? Now we give them 100% oxygen, and the arterial partial pressure of oxygen increases to about 660. So now it could either be a VQ mismatch or it could be a diffusion problem. Okay? Now you may be asking why I said So if both their oxygen partial pressure increases, how do we differentiate between the two, right? So if you paid attention in today's lecture, the doctor mentioned it. The doctor said that to differentiate between them is we use diffusion capacity for carbon monoxide. Carbon monoxide, okay? So if the carbon monoxide diffusion capacity is normal, this is a VQ mismatch. If it's less than normal, this is a diffusion problem. Clear? Okay, so this is where I will stop, and I was lagging. What part did you not understand? Why is the CO2 curve steeper? Okay, so the CO2 curve, the reason why it's steeper is because the oxygen plays a greater role. Look, the difference in our carbon dioxide is not, I explained it in the first slide. The difference in our carbon dioxide is not that much. It's because we need some of the carbon dioxide to remain in the blood. We do not remove the entire carbon dioxide when we're breathing air out. We need some of it to stay back. That's why when carbon dioxide is released into the blood, carbon dioxide already exists. So it doesn't, the change is not, the change is not big. It's a very small change. So the change is not big. It's a very small change. That's why that's why it's very minimal, because carbon dioxide needs to stay in the blood to maintain a pH. We can, guys, this is where I'm going to end. I did place a bunch of questions for you, but we're running out of time. So you guys can do them, and you guys can email me. I've put my email at the bottom of the first slide, and I will be more than happy to answer your questions. And yeah, please scan this QR code and leave your feedback. And thank you so much. Again, if you have any questions, you can ask right now, or I can answer through email. Of course, no problem.